Welcome to the Reinventing the White Coat podcast, where we delve into conversations aimed at helping you foster a healthy relationship with your career and yourself. If you're a physician feeling unfulfilled or burned out or want to prevent yourself from going down that path, then this podcast is for you. I'm your host, Jennifer Shaer, pediatrician, chief wellness officer, and executive and life coach. Sit back and relax as we explore ways to live your best life and have a career in medicine. Hello, everyone, and welcome to another episode of Reinventing the White Coat. Today, I welcome Dr. Grace Torres Hodges, who is a fierce advocate for direct care medicine, which I honestly did not know much about before you reached out to me, Grace. So I just want to start by thanking you so much for that outreach and for being here today.
You're welcome. Thank you so much for the opportunity to talk about this because it is a new movement, but ironically, it's old school medicine is what it really becomes. And so it's just a way, when you find something that works for you and it's very positive in your own life, you always want to share it with others as well. So thank you again for the opportunity to
it's
do
funny.
this.
Yes, everything old is new again, right? But listen, before we get into the details of what direct care is, and I want to hear about like the difference, how it is, because I always thought it was the same as concierge medicine, and I'm learning that it's quite different. But I was hoping you could sort of share a little bit about your story and how you found your way to this.
Sure. First off, again, my name is Dr. Grace Torres Hodges. I am a board certified podiatrist and foot surgeon practicing for the last 22 years here on the Gulf Coast of Florida. I had been in practice for almost 13, 14 years before I actually even heard about direct care. I started like everybody else after residency with paper charts and nothing electronic yet. We were still doing the beautiful soap note that we all learned when we were in school. I converted and complied like I with everybody else. I've always been a techie, so moving to computers was really not anything new. As each year went on, you do it because there's that incentive first, and then if you don't comply by a certain date, it becomes penalized. And then you realize, wait a minute, that's more like of a carrot and stick kind of way of teaching. And it didn't really get in the way of anything. And we're so programmed to be to comply with things. In school, our training is so regimented. Whether it's going through undergrad and getting your prereqs, taking the MCAT, going through school and getting into your residency, it's that see one, do one, teach one method.
Yes.
And you follow all those ahead of you. And what's the term that they use today? FOMO, for fear of missing out.
Right.
You comply. Otherwise, you don't get to see that case. You don't get to scrub in. You don't get to do something. So you kind of get used to that way of training. So when you were getting ready to finish residency, all of us said, we're told, what do you do? What do you do? You go into practice or do you get employed? And back when I was still finishing up in the late 90s, early 2000s, it was still the thing to hang your shingle out. That was something that everybody kind of aspired to. So how do you do that? Well, you open up a private practice and you get on insurance plans because you were told that's the only way patients can find you, and that's the only way you'll get paid. If you don't get on insurance plans, you won't get paid. And so that idea was always in your head. But then I was in practice for 13, 14 years, almost 15 years by the time I actually dropped out of everything. But I didn't hear about direct care or direct pay, sometimes that's referred to that also, until about 2013 when I went to a conference. And I heard about the idea of doctors not practicing in insurance and going just plain old cash. And I went through all the gyrations in my head about, how can you do that? You never talk finance with a doctor.
Right.
You don't talk money with a doctor because our profession is so altruistic. But then when you realize that you're not able to function properly in a private practice without thinking about how you're going to sustain financially your practice, you realize what is the factor that's bothering you. And as I began to look into it, I looked and realized that my mission was always to take care of patients. And I can only do that if I'm focused on my patient. But things like denials and coding and even just the delay of getting patients into my office because there had to be a referral that had to have prior authorization, or the medicine couldn't be delivered to them because that had to be authorized, when I'm the one seeing the patient, not the insurance company.
Right.
And so when you go into all that and you think about it, you realize, it's getting away from the mission of what medicine should be, which anything that was getting in that way was not part of what I wanted to be part of as well. And then something strange happened. Our toilet broke at the house, and I had to call a plumber. And so what do? I went and went online and asked my friends on social media, okay, who do you recommend? And they gave me names, and I called around and had someone come out to examine, diagnose, and treat my plumbing issue at the house with prices that were transparent and negotiated and agreed upon and completed, and both parties were happy at the end. Now, why can't medicine be like that? In a practice, that's all you want to do. When you ask for doctors, you ask your friends who you go to, your family, who you go to. So anyway, that side note with the plumber, that was one of the things that kind of took me over the edge, but that's how I got into direct care. And so that, it's a very a roundabout way of doing it, but then you realize that's the way it used to be. I think we all aspired to that when we were younger, that we wanted to be the doctor in the community that people came to. So that's what found it for me.
Yeah. That I feel like when I go to the dentist, that's the way the dentist still functions.
Right. Right, exactly. And the dentists, they had it right when most of the dentists didn't go into insurance, and so that third party really interfered. I think at first it didn't, because the premise was always good. I'm not an anti-insurance person. You need insurance, but it's meant to be for catastrophic things. Think of car, think of auto, think of property, think of housing. That what do you use that insurance for when there's a disaster? And I think if you can remember back, I think you and I are, remember back in the day when it used to be major medical.
Right.
That was what they used to call it. And when it became routine things being covered, it changed the perception of pricing. And unfortunately, I think it got abused, is what happened.
Yeah. I mean, this is really kind of hard for me to wrap my mind around, and I'm sure the listeners will feel the same way. So I have a million questions for you. But I will just, before we get into like the nuts and bolts of how this sort of functions, how has it impacted your sort of health and well-being as a physician and your patients' outcomes or their experience?
Let me start with probably with the patients first. I think I'm a better doctor for them because I can slow down. I could take my time with each patient. I can get a true history based on what I think is needed and the things that we learned when we were in school on how to take a history and everything, not based on a checklist on an EMR that you have to complete in order to get the coding right to get reimbursed properly. The care is definitely more patient-centric. There's no misaligned incentive. I'm just there to take care of the patient. There was no interference with, again, all the extraneous administrative things that third-party payers seem to throw into the loop of things. My team, my staff here in the office is happier. They're not spending their time arguing with why something wasn't covered, or staying on the phone for hours on end with an insurance company to get an authorization on something. So, when your team's happy, the overall office is happy. It's quieter. It's a lot calmer. My accessibility is there because I am able to, I'm available also. And, with the transparency in pricing, it's affordable, and it gives patients that independence again to make a decision. They should be the ones my mom, who's an internist, always told me this. And I remember when you get out of residency, um, you think, okay, I can do this. I can take care of my patient. And I remember seeing one patient. I deal with a lot of diabetic feet. I just fixed something. I just did a debridement on his foot. And this is when I was in residency. And I just happened to see this patient outside about a week after residency when I closed an ulcer on the bottom of his foot, walking around in regular shoes and thinking to myself, why is he not listening to me? I'm the doctor. I should know what's going on. But ultimately, my mom was the one that reassured me with that. And when I called her and told her about it, and she says, your job is to advise people. Ultimately, the patient has to have that responsibility to take care of themselves. And so, that kind of lifts that weight off of
Yeah.
you, and, when it comes to also choosing their doctor, they should have an independence to that. And so as far as how it changed, I think overall the patient experience in my office is better, my staff is better, and then personally I'm better just because, I remember coming home, and one of the things that again put me over the top was I was at home with a stack of charts from audits on insurance because they go back like 3 years to check and see, and you had to make sure you had to send charts off to get approved. Otherwise, they're going to take the money back that they already paid you. So,
Right.
long story short, I was working on that. My husband wanted to go to dinner, and I said, I can't. I've got the homework. And he goes, what are you talking about? And I said, I've got this. I've got to finish this, or else, or else they're going to, I'm in the middle of an audit. We have to get this taken care of. And he goes and says, what is that doing for the patient? And I go, and I was just dumbfounded. I had nothing to say. And he was right. It wasn't doing anything for the patient. I already had treated the patient. The patient was better. I was justifying what I was doing in order to take care of the patient to get better. And then a lot of those nights like that, I was fortunate. I could get to my children's events. But you always had to manage it around a very, very busy schedule. So my life is calmer now. I can tell you that much, just because I have control over that element of it at home. I can leave everything at the office. I can go home and I'm done, which is great. And so I think when that overall as an individual, when you can do that for yourself too, that's
Yeah.
that's probably the most important.
Yeah.
And we forget that as doctors.
Yeah. Yeah. No, for sure. And you mentioned that it's affordable. So let's talk a little bit. How is this affordable? I mean, this sounds sort of too good to be true. And also, how is it not concierge medicine?
Sure. So probably the best way to describe that and explain that is to talk about a very simple thing that everybody can do. Ask what the cash price is. Okay. So I'm going to use my mammogram as the example of it. And when I was, if you file your insurance, there is a set price that the facility will charge based on the code that is submitted. And I asked ultimately, what is my out of pocket for my mammogram? In this case, and I had not met my deductible yet, and this particular plan, I actually had to pay for it. It was almost close to 580. And then when I went to another facility, ironically, the facility is just down the way, same readers and same machine, but different facility. I asked what their cash price was, and was $99.
Huh.
I'm like, okay, why when I pay cash, and you could do the same thing with an MRI. An MRI filed to insurance is going to be a set price. But if you file through the insurance and the insurance doesn't pay, you're responsible for that insurance price, whereas a cash price is going to be totally different. And why is that? You have to then delve into, where's that extra difference going to, And when you look at it, you realize, I look at like stats, like even the Fortune 500 charts. Look at the Fortune 500 charts and see 25 years ago, there wasn't a healthcare executive on there. Today, healthcare executives of the major insurance companies. And again, it's just one of those things that you look at and you realize, wait, something's not right with this. But the affordability, if you're charged the insurance price, you're going to have to pay the difference of the insurance price if you still haven't met your deductible. And then the same thing, if you ask the cash price and just pay that cash price outright, you're done. The number one reason for bankruptcy in the United States is actually due to medical debt with those with health insurance. Why? It's because of that disconnect on there. But I'll use a better example. I have a patient that they're very accessible. My patients can reach me through text and they can call. She dropped, and I use this. I've mentioned this before elsewhere. She opened the freezer and a meat thing fell on her foot. Okay, what are your options? You can go to the emergency room and be seen as urgent care, get the x-rays, wait, and then get the x-rays and get treated, right? And who knows if they'll actually figure it out over there again, because you're not priority, because it's going to be the heart and the breathing folks that are going to get that priority first. But she called me within 30 minutes. I had her come over. We x-rayed it. I examined it, found the fracture, sent her home in a boot, and she went back to work. Set price for an emergency visit. The x-rays were included in my pricing also. But it's not just finance, it's time. Think about the time that you saved for the patient also. Going to the emergency room and the cost of an emergency room visit, the time in the emergency room physician, the x-rays in a hospital facility, and then the DME or any kind of durable medical equipment that they would dispense, which will also be upcharged because of the fact that they have to, you understand why the facilities have to do that. They have to make ends meet, but the time that she would have been there half a day, versus being in my office. So
yeah, but patients
savings
are still going to need
Oh,
emergency
absolutely.
rooms, right?
Right. Urgent, so direct care, one thing I think I maybe should mention is direct care is not the only way to practice. It is a way that I found in my private practice on how to deliver care and participate in the healthcare ecosystem. It worked for me. It's not for everyone.
Right.
There are some specialists and specialties that you can't do that. It's just not doable. But when we talk about independent private practices, which need to still be around, when 70% of private practices are being bought out by virtual capitalists and also hospitals, there becomes a groupthink mentality of thinking, and you need to have independence in medicine still. And so anything that I can do to save the independent private practice, that's kind of where direct care falls in line with it, and it worked for me.
Yeah,
So,
and I know this
yeah.
is super popular for primary care.
Right. And when you think about primary care, they have the major thing that they take care of are their major services visits is the visit. And if you have a healthy community, it works, but if you have a sick community, you're constantly being used and used and used and used, but you only get a set amount price. But yeah, what they call the direct primary care or DPC model has been fantastic with that. Their model works off of a membership, kind of like a Netflix thing, which makes it also, the other question that you had asked was what's the difference between concierge and DPC? And there's a difference between the financial model versus the experience. So the experience is concierge in the sense that you're being catered to, patient-centric and everything like that, a little bit more extra time. But there is a big difference in the model of direct care versus concierge. Direct care deals with no insurance. There is no filing of insurance. There is no insurance payer in the mix at all. Concierge medicine, those that practice in that model, they still are participating in insurance. So the patients can still have their insurance filed to it. It's a access to them that they pay a membership fee, typically at the beginning of the year, in order to limit their number of patients that they're taking care of. But they still have to deal with the headaches of third-party administration and the rules and regulations associated with that.
Right. And in a sense, it's they charge that in order
Membership
to
fee.
also that membership fee in order to help them make ends meet, and in
Right.
some cases
Absolutely.
to deal with all of the stuff. But by
Right.
getting rid of it, so explain to me, which is the my always go to, is how are you taking care of the neediest? Right? I mean, we
Well,
all go into healthcare because we want to take care of people who need the help the most.
right. One of the first things I think that the first thing you have to always remember is that you can't treat everybody. There's no way you can treat everybody. We'd like to think we can. We can't. We're not super people with that. You can't treat everyone. And so understand there's time and physical capability. You're not able to reach everyone with that. And the thing is that again, it should always be the patient's choice. There will be doctors that will serve in clinics. There will be doctors that will provide that will work for hospitals. There will be doctors that will be doing that because direct care model doesn't work for them. But as far as what I'm able to do, number one, my time in the office is intentional and I spend the time with each of my patients. It's also my discretion as to whether or not I want to give free service in my office or even volunteer outside. And because my timing in the office, I don't have to spend and see 26 to 30 patients a day because of not being sure if I'm going to get revenue reimbursed at the end of the day. Because insurance controls not just I get what I'm paid, but how I'm paid and when I'm paid or if I'll be paid. You know, your sustainability in a business, I'm not worried about that component. So I actually have time now to volunteer in community clinics. If a patient comes in and says, Dr. Grace, I can't afford this. And I go, we have the option of alternative payment plans. I can bundle services. I can do a payment plan based on, over time. I can map that out, or I can actually write it off. You know, I can write it off or I can barter. One of the funny things last week, I got corn, which was really, really cool. I wasn't expecting it, but that's how they gave me that later on. I had written off the visit because it was just something really, really easy. But I knew that they were down and out. They had just lost a family member, and it just was not. They were, they're not in that right space. So you really work with your community. And because everything that I do is relationship based now, that's really what it comes down to. Direct care has returned that relationship between the doctor and patient.
Yeah.
And you're just talking to your community and working with them. So, I get that question all the time. It's like, what about the need? You must not care about those that are poor. And actually, I actually have more time to spend with them now. And so yeah, it's doable. But again, it's the patient's choice. The patient has a choice to come to me. And some of my patients that do come to me, they know the price and they're surprised that that's all it is. If, again, I bundle everything together when I do my x-rays and the visit. They didn't realize that it can be affordable for them. And they will save up to come in and see me too. So, you know, it puts the onus back on the patient responsibility. I have a healthier patient base. Even my my economically struggling patients, they are actually healthier because they feel like they have a part of it themselves. I can do a lot more educating with them. Yeah.
Yeah, that's interesting. The old school, everything old is new business. I love that bartering mentality. I just think about when I took over my practice, it had been my father-in-law's, and he had been, in this farming community. And really, it started off that way. He would see somebody and they would paint for him, or, so much of that. And now you're just so afraid to violate any rules.
Right, right. But when there are no rules, when it's your rules and not
Right.
that third party, you can do, because you don't realize that, I remember when I was still on the third party payers, you see an older individual, and, it's so funny. I always hear the phrase, I'm on a fixed income. And I go, I don't know anyone that's not on a fixed income. We're all on a fixed income. But I remember, and I always felt bad, and I would write off. And apparently I wasn't allowed to do that, and you don't have to worry about that anymore.
Right.
And so, yeah, so you definitely, I feel like I'm more connected to the community as a result of it. Um, People come to me not because I'm in network, it's because they want to come to me. And that there's that mutual respect for each other. I think that returning that back, it's been so healthy for both
Yeah.
patient and doctor.
But Grace, at least the way things stand right now, for patients to see a direct, whether it's primary care or a specialty care physician, they
Mhm.
still need to carry traditional insurance, not just catastrophic. So if you had sort of like your crystal ball or magic wand, like where would you envision this movement in 10 years? Where would you like to see it go?
So, I'm so glad you mentioned that, because it's not, the doctors had to be the first ones to kind of start the push, because we're kind of at the center, and then everything revolves around it. My next thing that I'm thinking of is really when it comes to employers and the way that they choose the plans that they cover for their employees. You know, we're so familiar with brokers that work in what they call the major carriers like Blue Cross and United and Cigna, Aetna, and Humana. But there are a lot of other alternative insurance carriers out there. And a lot of companies are doing self-insurance. And basically, again, think of the way that you do your house. When you find insurance for your house, it's not a one size fits all kind of thing. What it is it's actually carved out based on how much your house is. What kind of features do you have in your house? Have you upgraded? How healthy are you? And all that. When you don't have to cover the whole umbrella of people, and I hate to use umbrella, I shouldn't have used umbrella because that will confuse people with insurance, but when you don't have to cover everybody in that group setting, and I the cost of the insurance will come down also when they start looking at self-insured plans. And I think you're going to end up with almost two paths, you know,
Yeah.
with the way healthcare is delivered, but also in the way that healthcare uh, is paid for, based on two things. One will stay traditional with, all the government and the federally, the bigger commercial insurances, and then I think you're going to have this other thing. I liken it more to like education. Um, we have public schools and we have private schools.
Mhm.
Okay. We all pay, and we all pay into our public school systems in our communities and everything like that. But parents have a choice. They have a choice to choose whether or not to use the public school system or not. And when they don't, they make amends and adjustments in their own budgets in the house to send their children to private school. And I think that's kind of where this is going to go to a certain extent, because we still have it's too big of a world.
For
So
sure. For
yeah, and
sure.
ironically, when I've talked to others that have lived overseas, um, and are in the socialized medicine
Mhm.
things, they have two paths there. Despite the fact that it's covered, there is that option for those to pick like a premier version versus the regular one. So
Yeah.
you do see it in that.
At the beginning, you mentioned something about how um, putting up a shingle
Yeah.
was something that people did. I actually think in primary care, and as a pediatrician in particular, it's people are few and far between who are willing and interested in doing primary care because of all of the hurdles that
Absolutely.
we're talking about. And some people who are still who are in private practice are really, really struggling and are, like you said, going to big hospital systems or selling out. if this is like pinging somebody's interest, right? Tell me, how can people learn more? Because I think that this is a nice option, whether you just don't want to sell out to a hospital, you want to keep practicing, or maybe I even see it as sort of like a pre-retirement, like you want to sort of slow down, but you do want to
Right,
still sort of work.
right.
This seems like a little bit of a burden off. So how could people dig into this more? You wrote a book about it, I believe,
I
right?
I did. I just released it last month. It's called The Private Practice Solution. It's one of several resources, but it's on Amazon and any of your favorite bookstores. And so, I use that as a basically kind of like a foundational footprint to start with, so that it can get the wheels in and everything in the head churning about it. But there are organizations out there that are dedicated to this: the Free Market Medical Association, the Association of American Physicians and Surgeons, the Direct Primary Care Alliance, the Direct Specialty Care Alliance. Um, there are podcasts out there also, um, like yours now, because we're doing this.
Right.
But My DPC Story and The Direct Care Way, those are two good ones also. Once you start going online, researching it yourself, and social media, there are several groups on social media, particularly on Facebook, where you can get into it and learn a little bit more. The community is very supportive of this, because this becomes a win-win for everyone, both the patient and the doctor.
Well, it's not a
So,
win for the insurance company.
well, no, it's not. But if the insurance companies are used the way that they're supposed to, will get a win with that. And so, yeah, it's when it comes down though to, if we don't have doctors continuing on, we want good people to go into medicine, like you said. It's hard to get them to consider primary care, particularly um, when they're being almost. There was a recent study by Merritt Hawkins on final year residents. Almost 80, more than 80% are approached by hospital groups to join their employment. That shingle is still available out there to hang, and
Yeah.
we just need to get that word out. A lot of doctors, and part of my book mentions this, doctors forgot, in order to get to medical school, you had to be entrepreneurial yourself. You had to sell yourself. You had to make sure that you were achieving as much as you possibly could. And there was so much independence there through your undergrad that you had to do. You have the capability of it. And probably the best thing, when someone that is currently in private practice or contemplating a switch to this direct care, you know, don't underestimate your power of ability of managing things, because I think that throws a lot of doctors off. I can't
For
deal with the
sure.
business, you
Right.
know. But what you have to remember is, every time you are treating a patient, it is like a mini business in themselves. Look at all the departments that you have to take care of, from cardiovascular to neurological to dermatological. I mean, each of those organ systems is a management group, and that is probably one of the toughest ones to deal with. So if you treat your practice like a patient, it becomes really clear as
That's a
to
great,
your.
I like that analogy. Uh,
So, but yeah, so I think it's there. It's just, again, I appreciate the opportunity to explain this and get people excited about it again.
yeah. And look, I think this just scratches the surface. But I do think it's a good place for us to wrap up for today. Thank you so much for joining me, Grace.
Thanks so much for inviting me on. I appreciate what you do, and anything that can help our fellow colleagues.
Yes. I say the one thing is the volume, volume, volume is what's killing us in healthcare, and anything that um, could help alleviate that. And this is definitely one of those options. So thank you. And I will also give, as I always do, a great big thank you to our listeners for choosing to spend your precious time with us today. And I hope to see you again on the next episode of Reinventing the White Coat. That's all for this episode of Reinventing the White Coat. If you enjoyed this conversation, subscribe now so you don't miss an episode. If you're interested in coaching or in being a guest on the podcast, you can reach out to me online at shaercoaching.com. Thanks for listening, and don't be afraid to live your best life.